So I am the last batsman. I hope you will be able to finish it in time. Okay. So the first slide you already know, that is question mark. So far you already know that in a COVID-19, there was when SARS-CoV-19 virus everybody was known. The chapter over after 1 year. And again second wave comes. And you already know that it comes in a different variant. That is a delta, beta or like that. Okay, I will speak here. So the different variant comes. So the same way, you already know that decay is there since decade. Then what is decay? Is it the same variant or like that? So there must be a lot of such type of questions in your mind. What is the difference between DKA and EDKA? Whether there is any difference in the algorithm, treatment protocol, what is the severity or like that thing. So the same questions will arise in your mind and the same questions arise in my mind also when I prepare this particular presentation. Okay. So in next 10 to 15 minutes, I will try to answer all these questions. Okay. Okay. So euglycemic diabetic ketoacidosis is an emerging, dangerous, life-threatening complications of diabetes. It is a form, variant of diabetic ketoacidosis. That is a DKA. That is already known since decades, you already know. And it was, second most important thing is EDKA is not a new thing. It is already known since 1970 also. The incidence of EDKA is increasing with the increasing use of sodium glucose transporter type 2 inhibitor drugs. Sodium glucose transporter, that is SGLT2 inhibitors, you already know that it's a medication that is highly effective in achieving the target HbA1c goal in people with the type 2 diabetes mellitus. So they are also useful in improving the cardiovascular and renal outcomes in people with type 2 diabetes mellitus, and therefore it is preferred in people who have existing cardiac or renal disease. So canagliflozin was the first SGLT2 inhibitor approved in 2013. Shortly after that, there were a lot of incidents of EDKA was reported in 2015 regarding SGLT2 inhibitor related cases of diabetic ketoacidosis. Since then, with the rising use of SGLT2 inhibitor, there has been increasing recognition of EDKA as more cases are reported. As per one study or survey in USA, there were increase in the number of prescriptions of SGLT2 inhibitor between the 2016 to 2021, and it has been reported that there is a rise in 114% rate of SGLT2 inhibitor prescription. And another study has also proved that there is a rise, or still it is rising, and so there is more and more number of use of these SGLT2 inhibitors are anticipated, and so there is a rising trend of EDK also, and that's why we are discussing it today. Coming to the definitions of EDK, diabetic ketoacidosis is a well-known acute and life-threatening complications of type 1 diabetes mellitus as well as type 2 diabetes mellitus. The DKA diagnosis is made by the triad of hyperglycemia, ketonemia, and elevated anion gap, whereas the EDKA, that is euglycemic diabetic ketoacidosis, lacks the hallmark hypoglycemia. That is the most important component of the diabetic ketoacidosis. So the difference between EDKA and DKA is the absence of relative hyperglycemia. EDKA has been defined as a blood glucose level of less than 200 milligram per deciliter, ketonemia, that is serum beta hydroxybutyrate, more than 3 millimole per liter, and at least one of the following criteria, that is arterial pH less than 7.3, serum bicarbonate less than 18 milligram per liter, anion gap more than 10. So if ketonemia and low level of blood glucose along with this one of the three is present, then it is considered as presence of EDKA. Further classification based on this pH and at bicarbonate level has also been suggested in one of the article, and it has different level, that the classification of EDK that you already know in described in this particular, that pH mild, moderate and severe, serum bicarbonate pH is less than 7.25 to 7.3, it is considered as mild, where at the same time bicarbonate is about 15 to 18, moderate when there is a 7.0 to 7.24 and bicarbonate level 10 to 15, and severe it is less than 7 and bicarbonate level less than 10. So this is the suggested classification in one of the article or journal it has been published. That's not. So this is already known. Then why it is important for us to understand this particular thing? Let us see the trajectory of EDKA in its incidences. The EDKA was first described by Munro in 1973 as a rare occurrence of in IDDM patients. Approximately incidence was 2.6 to 3.2 cases of DKA presented with euglycemia. So after all DKA cases, you consider this, it is was 2.6 to 3.2% having the euglycemia, and that was it is EDKA. After the EMPA-REC trial of 2015 and DAPA-CKET study in 2020 demonstrating the multivariate benefits of cardiovascular and renal disease, a continuous rise in SGLT2 inhibitor use is anticipated. And we had already, I had already told you it has rise to more than 50% rise in SGLT2 prescriptions rate between 2015 onwards. Numerous studies have corroborated the association of EDK and SGLT2 inhibitor use. An analysis of FDA's adverse reporting system revealed a 7-fold increase in the risk of DKA in the setting of SGLT2 inhibitor use, of which approximately 2/3 of the reported DKA cases fit the criteria for 2/3. So out of all DKA, initially there were only 2.6 to 3.2%. Now DKA having a presentation of this EDKA is nearly 2/3, means more than 60%. That is what has been reported. So this is why we are discussing it today. Other studies support an association between the use of SGLT2 in medication and EDK regardless of the duration of the. This is also one of the important. Whatever may be the exposure of this SGLT2 inhibitor, but there are chances of development of this EDK is almost same. Now what is the outcome? Morbidity, mortality. There are no available data on the mortality or morbidity associated with the SGLT2 inhibitor induced EDK. Exact incidence and mortality morbidity is not known. Typical DKA has a mortality rate of 0.65 to 3.3% that you already know. However, because of the diagnostic challenges and diagnostic dilemma of non-glycemia presenting in the emergency department, it has been said that EDKA has worse outcome compared to classic DKA. That is the most important thing we have to remember. There are certain data available with the pregnancy. The maternal EDKA can increase the rate of fetal demise, that is up to 9%, and increase maternal mortality. Maternal complications of EDKA also include eclampsia, preeclampsia, ARDS, acute kidney injury, coma and death also. Fetal complications include malformations, preterm labor, arrhythmias, respiratory distress, hyperbilirubinemia, hypoglycemia, neurologic disorders and intrauterine demises. So these only available things which I came to across. Now coming to the pathophysiology of EDK. This is also one of the important things. In another 3 to 4 slides I will explain how. Classic DKA mechanism, it is a clinical state of relative or absolute insulin deficiency and excessive counter-regulatory hormone response. Whereas in EDKA, the mechanism, it is a classical state of lower renal threshold or glucosuria and increased rate of glucosinosis and free fatty acid metabolism. That is why I think explained in this particular that there are two important mechanisms, that is insulin deficiency and counter-regulatory hormone increase in DKA classic, whereas in SGLT2 inhibitor there is a increased renal reabsorption, a decreased renal reabsorption. So SGLT2 inhibitor increases the renal clearance of glucose from proximal renal tubular epithelium, that you already know, and increase hepatic gluconeogenesis because of the low insulin level with augmentation of the urinary glucose losses with the SGLT2 inhibitor. Another possible mechanism is an elevated glucagon level that favors ketogenesis, that you already seen in this particular here it has been explained in particular thing that it is. Okay. So it has been clearly shown under SGLT2 inhibitor, the mechanism is prevention of the glucose and volume loss, whereas the most important mechanism here is the insulin deficiency and counter. At the same time, there is also effect on this SGLT2 inhibitor also affect these counter-regulatory hormones and SUL, so that there will be increased chances of EDK and in this particular setting. So insulin level with augmentation of urinary glucose losses is SGLT2 inhibitor. So SGLT2 inhibitor promotes a negative fluid and sodium balance, which in turn lead to exacerbating the hypovolemic state of DKA and leading to elevated cortisol, epinephrine and glucagon levels, further enhancing insulin resistance, ketogenesis and lipolysis. What are the risk factors for precipitants or the triggers? There is a significant overlap between DKA and EDKA risk factors. In EDKA, individual's metabolism is created towards a state of relative or absolute starvation. So triggers include anhedonia, anorexia, severe depression, or infection or sepsis, exertion or physical stress, decreased caloric intake, cocaine intoxication, trauma, dehydration, persistent vomiting, insulin dose reduction, omission, insulin pump failure or gastroparesis, acute pancreatitis, bariatric surgery or prolonged fasting and ketogenic. Even the alcoholic use disorder, glycogen storage disease and chronic liver disease also triggers the EDKA. Patients with low to normal BMI on SGLT2 inhibitor particularly are more vulnerable because there is a loss of glucose. The pregnant women are at a unique risk of developing both DKA and EDKA because it is a state of relative or accelerated starvation leading to decreased insulin sensitivity and increased lipolysis and ketogenesis. Finally, all these conditions causing metabolic acidosis can contribute to EDKA such as lactic acidosis, salicylate overdose, and renal tubular necrosis leading to renal tubular acidosis. So all these conditions can contribute to development of this EDKA. What are the clinical features? EDKA and DKA have significant overlaps in the clinical features. EDKA signs and symptoms include nausea, vomiting, abdominal pain, malaise, fatigue, shortness of breath, and tachycardia. More gradual onset of symptoms in EDKA compared to the classical DKA. Absence of pronounced hyperglycemia, hence there is absence of characteristic osmotic symptoms. So in EDKA particularly there is absence of osmotic symptoms, that is a polydipsia and polydipsia, and severe mental changes are also absent. Now what is the diagnosis? Diagnostic challenges. There is a gradual onset of symptoms compared to EDKA. There is a delay in diagnosis in the emergency department because of the absence of hallmark hyperglycemia component. There is a significant overlap between DKA and EDKA is a diagnosis by exclusion. So there is always, these are the particular diagnostic challenges, and because of this particular diagnostic dilemma or challenges, there is a worse outcome. A thorough history must be obtained which includes stressful condition, physical exertion, medications and substance use particularly. What are the investigations? Complete blood count, urine examination, serum electrolytes, LFT, metabolic panel, NIN gap, and arterial blood gas, blood sugar, serum ketones, particularly serum ketones is the most important thing. That is a beta hydroxybutyrate, acetoacetate, and because beta hydroxybutyrate contribute nearly 70% of the acidosis. All causes of acute anion gap acidosis must be excluded. Patients with diabetic and suspicion of one or more of these diagnoses should not preclude the possibility of EDKA because these events may precipitate in EDKA episode, particularly in patients on SGLT2 inhibitor. Based on this investigation profile, the staging of EDK has also been suggested. That is stages of, that is say 0, 1, 2 and 3, when there is ketones negative, ketones low, ketones moderate to large, anion gap less than 15, anion gap less than 15 on glycerol. Like that, there are 3 stages has already been described. Coming to the treatment. Treatment of EDK parallels that of only 1 or 2 slides. Sorry, just we'll finish. Treatment of EDK parallels that of DKA, except that the risk of relapse into DKA is high in the setting of SGLT2 inhibitor. The basic principles of EDK treatment are that IV insulin, IV dextrose to maintain the blood glucose, because there are high chances of hypoglycemia. Advanced diet and or give carbohydrate to replenish the glycogen, and monitor the ketones and anion gap and not the blood glucose. This is the treatment algorithm that I had already said, that are most 4 important principles, and we have to correct this ketonuria and anion gap. If there is ketonuria and anion gap is present, then we have to again go back and transition to subcutaneous insulin if both are absent, ketonemia and anion gap. So what are the prevention? It is the most important. At the patient education, educating patients on the risk and symptoms of EDK. At the healthcare provider education, signs and symptoms of monitoring ketones in normoglycemic patients. Seek their rules, guidelines on managing blood glucose during illness, and close monitoring, regularly monitoring for patients of signs of EDK. And they have also suggested that every weekly you are supposed to monitor these ketones, capillary ketones. That is also suggested. I think that is all. Certain salient important feature, or what I will tell, it is a take home. In the acute setting, SGLT2 inhibitors should be paused. The patient may need longer treatment for EDK in the setting of SGLT2 inhibitor use. The chances of relapsing back into DKA are high if the insulin drip is prematurely stopped. Restarting SGLT2 inhibitor after the resolution of EDK should be individualized or personalized. And intra-abdominal or cardiothoracic major planned surgery SGLT2 inhibitor should be stopped 3 days prior as per the ADA 2020 guidance. But another study has proved that in the preoperative period, stopping the SGLT2 inhibitor 24 to 48 hours before surgery did not have a significant outcome. So I think that is all what I am going to tell you. Thank you.